All right, my demons, minions. We're in Airway 2 now. So moving on to the subject matter that we had from the last class, Airway 2. So some of the adjuncts we use, and one of the things I've said a lot to you is knowing which adjunct to use at which time. You can't fix a CPAP problem with a nasal cannula. You agree? You can't fix you can't overwhelm somebody with a CPAP when they only needed a nasal cannula. CPAP's very invasive and it could feel like they're suffocating. It could cause an anxiety attack. There's a lot of, and you don't want to intubate somebody that's talking to you normally. So in that, we have to learn and understand the equipment and tools we use. I don't know if y'all do this here, but in the recruit school, I believe it'd be very necessary for you to do what's called touch a truck. One of the very first classes my EMT students have is that I bring an ambulance out to them, one that is in service, one that is being used before it goes in service. It is ready to roll, right? And they touch a truck and they go through and there's an instructor in there and they pull out every bin, every tool, every toy, every nook, every cranny. They explain everything. That takes up some time, valuable class time, but it's very important to know kind of an idea of what all this stuff's for. Well, this is simply just sterile water. We clean the suction equipment with this as we go in and out of the patient's mouth. We also can debride wounds. What does it mean to debride? Well, it means to clean them up and get dirt and trash out of them. Most people that wreck motorcycles, when they get abrasions on them, they are skinned up by this dirty concrete. There's chunks of concrete, dirt, bugs, and everything else in there. You kind of want to get that out. So that's an important concept. So for you guys, and this these equipment here, you have to know the tools of the trade. How many can honestly say that there's actually equipment on your truck, on your ambulance, that you kind of have a very loose understanding of what it does, or you have no idea of what it's really for? What do you think? Some of y'all yesterday were mind blown when we were telling you that the life packs have a button. You can hit a button and switch it over to a carbon monoxide monitor. Did you know that? Ish. So understand your equipment. So the non-rebreathing mask in the pre-hospital setting can get that oxygen concentration, that FiO2, up to 90 to 100%. How? It has a big bag that has an oxygen reservoir with molecules floating all around it. You know what's something funny I've seen, though? I've seen a paramedic actually put one of these bad boys on and not inflate the bag. Is that going to give them the 90 to 100% O2? But why, though? Because it doesn't have the reservoir bag on. So who do you give this patient to? Yeah, who do you give this treatment to? This is like the firefighter's favorite thing to put on everybody. Oh, you ain't feeling good? You got a broke leg? Here's a non-rebreather. You having some trouble breathing? You got a 94% stat? Here's a non-rebreather. So who's getting this?
Anybody that possibly could have smoke inhalation, somebody that's just not sounding properly. That honestly could also be used as a treatment to calm somebody down as a placebo.
Ooh, that's very good. Believe it or not, placebos work. I've healed back pain with normoxylene or that new French drug for pain, sodium dichloride. It's good stuff. But also for the anxiety patient, it just feels like the world is not crashing in. Somebody's doing something for me, and it gives them that level of comfort. Not all medicine is electricity and drugs. There was a woman that was super psych patient, and she was literally seeing little green men. And believe it or not, just me and her just humming gospel songs one night on the way to Grady just took those things away. That was medicine too. You find what your patient needs, you give your patient what they need. I don't care what it is or what it looks like. So somebody that's having a little trouble breathing, you can give this to them. So spontaneously breathing patient that just need more of an oxygenation versus ventilation. Martin, is a non-rebreather ventilation or oxygenation? Oxygenation, very good. It just puts more O2 molecules in the patient's body. Will it ventilate them, Chamberlain? No, sir, it will not. It does not move air in and out. Therefore, it is not ventilation. So contraindication of that will be apnea. If they're not breathing, it's not going to do a whole lot of good. Or if they got really poor respiratory effort, it's not going to help them a whole lot. Now, what about your old cannula here? That can bring your O2 sat concentration, your FiO2. What does that stand for? High. Your FiO2, what does that stand for? Good. That's an answer. I have no idea is an answer. So that stands for the fraction of inspired oxygen. So inspired is what you breathe in. The fraction is the percentage of oxygen the patient's actually getting. You dig? So 21% is what you're getting right now. So 0.21. What would 1.0 be? 100. You're right. That was a great guess. Keep it 100. I like you. So with these adjuncts, we need to understand they got limits. There's limits to this game. So the nasal cannula would only be able to give 24 to 44%. The range of liters per minute that you give the nasal cannula is 1 to 6 liters. But I can go ahead and tell you, if you got somebody on 6 liters with a nasal cannula, you probably should think about graduating them to a bigger device or a more powerful device. Because at 6 liters, have you ever seen that happen? What are they doing? It's just blowing their nose hairs all the way down their trachea. It's a lot to put on them. It sounds uncomfortable. So at 1 liter per minute, what can I expect possibly for the FiO2 to be? What do you think there? Wrath, tell me about it.
So it's 24 to 40%.
Just give me a guess. Usually.
So that 24 to 40%, that's that like 6 liters?
Exactly. So at 6 liters, you're probably around that 44% range. So at 1 liter, where are you at?
About
24%. Very good. So sometimes there's no trick question. It's just like find the A and the B and put them together. That's a good job. It's not going to work very well for patients that are having apnea, no respiratory effort, hypoxia. Severe hypoxia needs a bigger gun than this. Your job is to assess the patient and understand which adjunct to use. Registry is famous for actually just seeing which adjunct you want to give. And 80% of the National Registry Paramedic test it's EMT basic stuff. Their belief is that as a minimal competency performing paramedic, you should be able to do the basics perfectly. And that the other paramedic ALS stuff should be done after the basics have been achieved. So this is best for patients that need long-term therapy. Why is that? It's not invasive. It's very gentle. It cannot normally cause harm, but that does not mean that long-term nasal cannula therapy cannot injure a patient. What can high doses of oxygen do? Ooh, it can knock a hypoxic drive out on a COPD. Very good. What else?
It can cause oxygen washout where it removes the nitrogen from the alveoli, causing the phosphate collapse.
Very good. So that's absorption atelectasis.
What? No.
How do you say that again?
Too much oxygen over a long period of time can cause oxygen washout. Basically, it just starts to slowly replace the nitrogen that helps keep the alveoli expanded and open at all times. You could cause atelectasis.
Very good. So the nitrogen that we breathe in, it's not useless. It does keep the alveoli open because it's a thick, dense gas. And if you have nitrogen washout occur, you could have absorption atelectasis occur, where the alveoli just stick together. Another thing is that the oxygen being warmed and humidified? If it's not being warmed and humidified, it's going to be drying out the mucosa in the lungs. That's another thing you got to think about. So oxygen delivery devices, we have the partial rebreathing mask, non-rebreathing mask, mouth-to-mouth device. I'm going to tell you, I stick with the big 3. A cannula for small problems. I neb people that have wheezing. A non-rebreather for bigger problems. A CPAP for the biggest problems. An intubation for the worst problems. I don't really complicate it. There's like a partial rebreathing or a simple face mask. I don't even really use. I don't find them useful. I'd rather overdo it than underdo it. Does that make sense? So like somebody yesterday was telling me about, could I just do albuterol for an asthma patient? I told him you could. Based on your assessment, if you think albuterol is going to knock it out, then go ahead and do it. But if you call me, I'm going to nuke your lungs. You're getting albuterol. If you have no contraindications, you're getting mag sulfate. You're getting Decadron, because asthma is a disease of mucus production, inflammation, and bronchoconstriction. So I'm going to go ahead and give you everything that I can and give you without it being too invasive, to make sure that while you're with me, you have no problems moving forward and that we can have some actual relief take place. I will not see the relief take place from the what? From the administration of the steroid, but patient will have it, because how long are they going to sit in that ER? right now, a hot minute. How many level 1 trauma centers are in Atlanta right now? One. There ain't but a couple of hospitals in Atlanta now. We've lost 2 hospitals in the last year or so.
Yeah.
We lost AMC South, we lost AMC Main, the other level 1 trauma centers. So we've lost 2 hospitals in our catchment area. So now the choices are Emory Midtown, Piedmont Atlanta, and Grady. Anything else is going to take us way out of zone. The only time I was able to ever go out of zone when I worked at Grady was because the pipes had burst and the whole ER was flooded in 2018, 2019. It was 18. That sucked, but I got to try a lot of new food. But that also takes a 911 unit out of the area. How long is it going to take me to get to Kennestone? 30, 45 minutes. I'm at the ER for another 30, 45 minutes. It's going to take me another 30, 45 minutes to get back. Do you see the problem? We're a whole unit down for a hot minute. And you got a question? You just stretching? Okay, cool. So these are things that we have to consider. Partial rebreathing mask. Let's talk about not talking about it. So a Venturi mask, this draws room air into a mask along with oxygen. Do you see the color-coded little dials there? The inserts represent different FiO2s. What's FiO2, huh? Yes. The fraction of inspired oxygen. Very good. So what does that represent? No, you can have it.
The amount of oxygen or the percentage of oxygen you receive from whatever device you do.
Okay. So it represents the amount of oxygen that you're receiving. So those different color-coded little Venturi mask inserts, they represent different FiO2s. One's like 24%, one's 28, one's 40, one's 60, one's 80. And this is good for patients that you take on transfers or to different locales.
So giving oxygen to somebody that's struggling for the time, possibly run hypoxic drive, so you don't overload them.
Absolutely. Absolutely. It has its place in use. I never saw it in the 911 market. When I did critical care transfers, some of the patients were on Venturi masks. I never saw it outside of that, but then I haven't been everywhere. Yes. No. Each different color-coded insert represents a different one. So one will be 24, one will be 28, one will be 35, one will be 40, one will be 98. They're all different. Depends on who makes it.
See what you're saying. I'm sorry.
It's all right.
I guess what I meant to say is not the percentage of oxygen you give, but the liters per minute. And if so, what is 24 is 1, is 28. So is it still 1 through 6, like how the nasal cannula is 24 through 44%?
So you just pretty much turn on the O2 tank at, like a good 8 to 10 liters per minute, and the insert will decide how much O2 you give.
Thank you. Okay.
What are you supposed to get it for?
It's really good for patients with chronic respiratory diseases like COPD, maybe some we're talking about emphysema, bronchitis, chronic bronchitis. We're talking about patients that are maybe having lung cancer. Matter of fact, something we could talk about that's not part of your curriculum that I'll just mention is called an Airvo. Airvo is super high liters per minute nasal cannula. It's even got a thicker tubing, like you put it in the patient's nasal cannula, and it can go up to like 40, 50 liters per minute. But it's powerful enough to push into the lungs to open alveoli and help them breathe, but it's gentle enough not to pop and destroy lung tissue because it's still a cannula. I've only seen that kind of call on like patients with serious long-term lung diseases. Airbo. Airbo. Trach masks. They cover the stoma. What's a stoma? Chamberlain, tell me about it.
It's a little hole that's cut into your trachea because of some kind of respiratory condition where they can't breathe through their mouth.
Very good.
Just take a breathing tube down there typically.
Very good. So a stoma is a hole basically that's cut in the patient's neck. There's a neck strap and usually like a little securing device, and they got a little clearing thing they put down there that you can put that plastic device and then help clear the airway because of this exposure to the open air, that stoma, that tracheostomy develops a lot of mucus production and lung boogers. You have to suction these patients pretty often. And when you pull them out, you pull out whole plugs, a mucus plug, lung butter. Actually, it's quite good on toast.
Sure.
Ah, you got the reference. Give yourself plus nothing. But you have my respect.
It's the air bubble is humidified.
It's humidified. That's what makes it even better. It's humidified, but it can also go up to like 60 liters a minute.
Yeah, that's a very thick tube.
It's thick. Thick with 2 C's. Like me. Oh, well, I'm recording. Whoops. Oh well. So usually these tracheostomies are at intensive care units. You're not going to be creating these in the field. Now, can you at the National Registry Paramedic level create a surgical opening?
Yeah.
Yes, you can do a surgical crike. Not in Georgia. Let me say that again. Not in Georgia. But remember, you're taking a National Registry Paramedic exam, and if it's an option, if it's the only option, you can do it. It is better than who? The needle crike. And death. So the stoma, you had to make sure that you're aware that these guys will clog up pretty quickly. Matter of fact, I've encountered these at nursing homes, and so when I work 911, you find them at nursing homes. You'll also find them at for doing transfers. Again, critical care transfers. A lot of these patients have a trach mask on. And even if you suction them, it could be 10 minutes, 15 minutes. They're going to be needing a suction again sometimes, depending on their production of mucus. It could be bad. So that's how you keep them breathing. So these are very common in intensive care units. And it's usually some type of respiratory disease or some reason why they could not breathe through their mouth to where they now have to have a hole in their throat. If you and your loved ones have been affected by mesothelioma. What? It could be that patient. Keep smoking, Renee. See what happens. It was asbestos. It was all the years of them not putting that vent thing on the firefighting engine bay. If you are in emergency services, you need to get a yearly chest x-ray. Do I need to explain why? Tuberculosis, but also you could develop lung cancer to the carcinogens you inhale. Black. Zoolander. So get your yearly chest x-ray if you work in emergency service. Even if you work for an ambulance service, I can tell you that sitting there in the ambulance bay and then working in and around that thing, you're around that exhaust a lot. You're inhaling a lot of things. You're going into industrial places. You know, it's a thing. Just take care of yourself, do yearly physicals. Now, what about oxygen humidifiers? Tell me about it. Why are you going to put them on humidification?
To decrease their chances of possibly becoming dehydrated, since a lot of your water is lost through respiration.
That's true. The average adult loses about 1,800 mLs of fluid per day just by respirating. When you breathe out, there's heat droplets of water. You lose a lot of water per day.
Also, to prevent the alveoli and bronchioles from becoming inflamed due to drying up and trying to expand on ventilation.
Very good. Those dry glasses can rapidly dry your mucous membranes, and you don't want your alveoli sticking together. What's it called when the alveoli collapse, Martin? What is it called? Pneumothorax is when the lung collapses. There's air trapped in the thorax. So pneumo air, thorax, chest. So usually it's trapped in the pleural space between the two. So tell me what atelectasis is. I ain't asking Kyle. I want you.
Where the alveoli kind of dries out.
They collapse. Atelectasis is just a fancy word for alveolar collapse. You got it. So ventilatory support. Patients who is not breathing needs artificial ventilation. I harped on this so much in Airway 1, but I'm like a dog with a bone. I just don't let things go. I want you to understand very, 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 very well. There's a big difference in oxygenation, ventilation, and cellular respiration. So gas exchange is when the O2 molecules come in from the outside air. Because of the pressure gradient difference, we have a gas exchange take place through the process of diffusion. And between the pulmonary capillary bed and the alveoli, we have that gas exchange take place. Carbon dioxide goes out. We get rid of the waste, which is the byproduct of the cellular respiration. But ventilation is simply moving air in and out. It's a mechanical process, and it's one you can participate in, either using a bag valve mask or put your lips on that patient. Oh, personally, you will all die. I will not put the one time you do that, patient's gonna vomit in your mouth. You don't believe me? Go ask Sergeant Marcus.
Can you do the CPR? Cause somebody comes to me.
Go ask him. I bet he don't do it no more. So, why do we give ventilatory support? So, altered mental status. Some patients might just be breathing so poorly, you may have to actually give them ventilatory support. So, how do I calculate a patient's minute volume? Hi. How about we calculate respiratory rate times tidal volume? I figured that's what you was about to say. I read your mind. We're on the same wavelength.
I would really go to having breaths. I wouldn't know get the other part.
Well, that's fair. So just keep it simple. How fast you breathe per minute, how many times you breathe in a minute, and how deep the breaths are. How much air you bring in and out. So the frequency of your breaths and the depth of your breaths, it does matter. And based upon the depth and the speed in which you breathe per minute, that is going to be your minute ventilation, how much you're breathing in a minute. And the average adult's breathing between 5 and 6 liters per minute. The average tidal volume for most people is about 500 mLs. Let me say that again. The average adult's breathing in between 5 and 6 liters per minute. And the average tidal volume is going to be between what? About 500 mLs. Again, it's based on body weight, but it's on ideal body weight.
About 10 breaths a minute.
And that's the title, not title volume. Is it the title volume?
What are you asking?
Respiration times title volume equals minute.
Ventilation. Mhm. So normal ventilation versus positive pressure. Your normal ventilation is based off of negative pressure. Your chest actually works like a vacuum. The diaphragm contracts and it starts to actually suck air in. So when I tell you you suck, I mean it. You really do.
Oil's law of gas exchange.
Yes, it does apply. It do.
Diaphragm moves down, increasing the volume of the lungs, causing an area of low pressure causing high pressure area to move through it, causing suction.
So let's make that more firefighting. So basically, the diaphragm contracts.
Syringe and you draw that the syringe and you stick it in the valve, kind of like this. You press it in and
Kind of. Let's say I had a water bottle up here. And I squeeze the water bottle. It's going to want to return to its normal shape and equalize the pressure inside this chamber, right?
Mm-hmm.
So as I squeeze it, it creates negative pressure and sucks air in. As I release it, what happens? It tries to equalize the pressure. The pressure outside here, the atmospheric pressure, is going to push air inside to this bottle, like your chest cavity. And the chest and this structure and your chest cavity is going to do what? Suck air in. So you got two types of things happening. A pulling motion, a sucking of your chest like a vacuum, and a pushing motion from the outside atmospheric pressure. Why is it doing that? Homeostasis is a good answer, not the one I wanted.
Atmospheric pressure and partial pressure gases.
So atmospheric pressure and partial pressure gases are trying to do what? They're trying to equalize the pressure inside your body. Now, what do we breathe off of again? Okay. Carbon dioxide drives our respiratory drive, but we breathe a negative pressure. Negative pressure is what we breathe off of. So positive pressure is generated by a device that forces air into the chest cavity from the external environment. So give me an example of positive pressure. CPAP's a great one. Continuous positive airway pressure. CPAP's a very, very effective and powerful device. I like it a lot. Do you know what we had to do before we had CPAP? Let's say you have that CHF patient, okay, and they got fluid on their lungs and they're having a bad time. What did we do before we had CPAP?
Do you have to ventilate?
Yes, but we had to do a awake nasotracheal intubation. And we can only provide positive pressure in their lower airway by ventilating them through that intubation that we did through their nose. Now,
There's a picture on the page.
is there?
It was a hand in a guy's mouth. I
Hey.
thought when I saw you talking about not putting your hand in somebody's mouth, but it's like they were grabbing a tube
Yes.
and pushing it down the throat.
So that sounds like digital intubation. So this week or next week, I'm gonna show you all my dirty tricks.
That's technically a EMT skill,
Could be.
blind digital innovation, because EMT is.
Hell yeah. So digital intubation, why is there a place for that? I can tell you, I've only done it like a few times in my career. Cars flips upside down and it's in a ditch so deep. Like it's like an 8-foot ditch and it's stabilized. The cribbing's good. So I crawl down there. I crawl in the car. Dude's hanging upside down. Can I actually use my laryngoscope blade and get it? There's no room. And he's losing his airway. He's dying in front of me. So what do? Go. Crawl the fingers back there to the epiglottis. I pull back the hood of the leaf-shaped flap myself and jam a tube down there. What you look at me like that for? He lived. You welcome, citizen.
Folks, they ain't got no teeth.
No teeth is a good one because we need that structure for the seal. But back in the day, before we had CPAP, we had to actually just put a tube down their nose and put it in their chest. And that's how you could use that positive pressure, because that positive pressure is going to force air in the chest cavity, but it's also going to force that fluid where? Back into the vascular circulation. Back into the vascular circulation.
Have you ever done that?
What?
The nasotracheal innovation, trying for CHF?
So they were phasing it out and putting CPAPs on trucks when I was a brand new medic. So that'd be a no.
I was about to ask, because like I heard that when you use nasotracheal innovation, you use basically the tubing for a stethoscope to make sure you're in the right spot, listening for sound.
So you're right. You can't use the stethoscope, but you have to have a special form of stethoscope that helps verify you're in the right spot.
And I was gonna ask if like you ever heard like the sound of like the straight lungs breathing through CHF while trying to.
I've heard videos of it, but not like if I have a wet lung patient, yeah, I've heard it, but like through that special stethoscope that you need. So to do the nasal intubation, you have to have that special stethoscope to actually verify in the right spot, and they actually have to be spontaneously breathing for it to work. But the reason we talk about these different intubation techniques is so that you always have an option for your patient. I told you in Airway 1 that you cannot fail at getting an airway. You have to have some answer and have an airway somehow. So if that means digital intubation, nasal intubation, digital tomahawking a patient, that means a video laryngoscope, if that means a crike, if that means a rescue airway, you've got to have an airway answer. And your paper this week being about the justification of intubating over an iGel or some other supraglottic airway should help enlighten you to that. There is a place for a supraglottic, but it shouldn't be your easy button that you go to first, because it's not the most optimal airway. It's not good patient care. Feel me? Yeah. So I don't care about that. So with positive pressure, more air is needed to achieve the same effects of normal breathing because it increases intrathoracic pressure and blood flow is decreased. Why do you think we have a reason that we say that if you give a patient CPAP, they have to have a blood pressure of at least 100 systolic? Because that increased pressure in the chest cavity will compress the vena cava, and it will reduce blood returning to the right side of the heart. So blood flow will be decreased. Your patient must have a certain blood pressure to receive CPAP. Wrath, let's walk through something. You got a CHF patient that's having an exacerbation. They're having some serious trouble breathing. They got pink frothy sputum. their lungs are wet and they're not doing too hot. You're going to put them on a CPAP. That's what you want to do. But their blood pressure is like, let's say 88/40. Can you put them on CPAP? What else can you do? What can you do for this patient to save their life? They need positive pressure. What's that?
I get ahead.
I gave you all the answers you needed. Well, let's think about it. They do not have a pressure that is high enough for me to give them CPAP.
You need something to drive secretion.
I don't want to dry any secretions up.
Vasopressor.
A vasopressor. Now he's thinking either a small fluid bolus or a vasopressor to bring the pressure up. Hey, the pressure's up now. Look at you. Here's your CPAP, sir. So if the patient is like right underneath that line right there, think about a little small fluid bolus. Not a big one because you don't want to drown them out. But you can either do a small fluid bolus like a 5 ml per kg, or you can think about a vasopressor like a Levophed, like a dopamine, like an Epidrip, something to squish those arteries, bring that blood pressure up high enough to where we can do what? CPAP works now. You meet the criteria, sir, and that'll save their life because they're literally going to drown in front of you otherwise. Does that make sense? Very good. Good job. I'll keep you. Makes sense, so don't it? There's no trick question to it. The pressure's low, bring it up so you can use your CPAP. So normal ventilation versus positive pressure. Cardiac output is a function of stroke volume times heart rate. Cardiac output is also what? The amount of blood that your heart's going to move in a minute. What is blood pressure? Stroke volume times systemic vascular resistance. What is stroke volume? How much blood comes out with each stroke? What is ejection fraction? The percentage of blood that's coming out. The heart's not going to pump every bit of it out. So the ejection fraction, the stroke volume is either going to be, it should be about between 50 and 70% to be normal. Below that, we're looking at a poorly functioning left ventricle. Everybody with me? So tell me about afterload. What is that, Martin?
The amount of blood left in your heart after each contraction.
Afterload, I was thinking more along the lines of the pressure that the left ventricle must overcome to pump blood. Preload is the left ventricular end diastolic volume. So that'll be the blood left over in the heart. That is the fluid in the blood returning back to the heart. That's in the ventricles after the systolic has made its happen. Make sense? Why does that matter? Because positive pressure can affect that. Positive pressure will drop the preload. How else then can that affect your patient? Let's see. Chamberlain, walk me through something. You got CPR going on for a patient. You also have an overzealous rookie bagging the living crap out of your patient. Now, a BVM is providing what type of pressure? Positive pressure. Very good. What is he causing to happen inside that chest cavity that is working against who?
He's building up pressure, simple pressure on the heart. To decrease your preload, and if that's happening, less blood is being pumped out to the rest of the body.
Very good. So what we're saying is you got a overzealous bagger and they're bagging too much, too hard, too fast. They're actually working against your compressor because positive pressure increases the pressure in the chest. It's going to compress the vena cava. So it's going to reduce the amount of blood coming back to the heart. You see the problem? Or don't you see the problem? I can do it again. Who's lost? All right, you. Where you lost?
Yeah, this is one of our 10 questions. I guess I'm actually lost, so I just want to make sure. Decreasing preloading, decrease in stroke volume, and it's decrease in cardiac demand. That's
Not
right.
demand.
That's wrong.
Not demand.
Yeah, so I guess I'm lost on if the stroke volume decreases and the preload decreases, then why does the cardiac demand increase?
So cardiac demand is based on intrinsic and extrinsic factors based on need. Me sitting here talking to you, I'm not burning a whole lot of energy, but if I go and walk up a stair, that might increase my demand for oxygen and my body's needs. So based on, let's say if High goes postal and he comes in here with like a pistol or something, he's mad. Don't do it. Remember, I was nice to you. So if he came here with like that, we would all have a sympathetic response, right? We dump adrenaline, that heart rate would jump up because the demand is I have a fight or flight now that's going to occur. Make sense? But if not, then let's stay here until you make sense. Like no child left behind. Does everybody else understand? So cardiac output is how much blood is coming out of the body, out of the heart, how much it's moving and circulating within a minute. It is stroke volume, which is how much blood comes out of the left ventricle with each contraction. And heart rate, the rate's determining how fast it's beating, slow or fast. You have to have a certain rate to meet metabolic demands. If you've got a heart rate of 20, can you perfuse your brain, your heart, your lungs? No. If you have a heart rate of 190, can you perfuse your heart, your brain? No. It is really dependent on your rate, because at this speed of 190 beats a minute, the rate's there, but the stroke volume is now what? Decreased because it's not having time to refill. Everybody with me? So cardiac output is a function of stroke volume multiplied by the heart rate. When a person breathes, those ventilations can do what? If you're bagging a patient, it can increase the pressure in the thoracic cavity and squish the vena cava. So like a water hose, it's flowing perfectly, but then you kind of compress the water hose, less water comes out of it, right? So less blood will be returning back to the right side of the heart. Everybody with me? Hi. Okay. So ventilations that are too forceful can do what? Cause barotrauma, but also ventilations that are too forceful will cause gastric distension. So you're bagging your patient like, what's that doing? That sphincter at the end of your esophagus. And what's a sphincter? Martin, you're the expert. An opening that has muscles around it to keep it kind of closed. Yep. So that force of the air does what? Meh. It forces the sphincter open and gases will go into the stomach. And guess what will happen next? Gastric distension and vomit.
And increased pressure on the anterior vena.
And that I don't want. So I'm not even going to talk about mouth to mouth because we ain't doing it. Do you need a barrier device? Because everybody's got Ebola unless proven otherwise. Treat every patient like they got Ebola. Why? They might have Ebola. I wish I had me like a Geodon dart like that. Like a Howdall Versed combo. It would be really cool. Because sometimes getting super close to sight patients is not my favorite.
Somebody will be shouting down and then kill it.
You're right. Somebody's gonna ruin every good thing we get. Probably a fire department too. So mouth to mask. Before we do any kind of techniques on anybody, it all starts with good positioning and airway and head movement. Aligning the axis by a head tilt chin lift. We saw that if you align the axes, you can visualize the trachea and the glottic opening better. But also, there's less tissue in the way and the air can flow better. Does that make sense? So if you're going to do mouth to mask, make sure you got a barrier device to help you. The one time I put my mouth on a other human being at work was a baby. And I was like, you know what? At your age, you couldn't have too much going on. And again, I can't mitigate all your risk, right? There's some risk to this job, right? There's a possibility you could get hurt or anything like that. So to minimize that risk, we do things that try and protect us. But every now and then we do something that's maybe a bit cowboyish. And again, I'm not going on record saying to go freelance or anything. Make sure that's on here. I'm just saying that I personally have made some emotionally charged decisions that did hurt me. I regret nothing, but I have been hurt by these decisions. But did it have a positive patient outcome? Yes. Did it sometimes actually even help my partner from doing something stupid? Yes. But I'm not telling you to go do that. Scene safe, PPE, BSI, always. But I can't sit here and look at your eyes and look at your face and say that you haven't already done some stuff like that. Unless you work at the training center and you're a desk boy. I'm sure you've made a decision like that, right? Put yourself in a line of danger for a crew member or a patient. It has happened. Just be as safe as you can. There's no greater job in the world than what we do. It is a lot of fun. I would give anything just to go run calls again. And I can do it for a short amount of time. I proved it myself a few weeks ago. I went back to Grady, did a shift. I'm like, ooh, that was fun. My back was sore for 2 days and, so you have the greatest job in the world. And one day when you look back, you were like, man, that was a privilege to serve. So enjoy it while you can. Last night, I was tired. I really was. I was teaching your class and I was pretty tired. Like I was beat up. I'd been here 12 hours. And then I sat and thought to myself, you know what? Why don't you just sit here and be grateful for the opportunity? This is the first time that the Atlanta Police Department's ever had an EMT class and you get to teach it. That's a great opportunity. That's a resume booster. And also the people in that room, they're a lot of fun to play with. They're a lot of fun to pick on and they're good sports. I enjoyed the time with them. So I decided to just enjoy myself and then really revel in the moment of it. Because I've noticed throughout life that sometimes while I'm in the thick of a season of my life, I'm like, this sucks, blah, blah, blah. But looking back, it was always a good time. When I was in South Georgia working as a paramedic, I didn't make hardly any money. Or to like $40,000 a year. It was pretty bad. But we were like family. And it was, in the time I wanted to get out so bad, go make the big bucks and big money. Now look at me, up here, teaching for the Atlanta Fire Department. I never saw this in my wildest dreams. But I still miss that season of that family time of me being on that truck. So I know this is veering off subject for just a second, but I want you to really sit and think about it. You have the greatest job in the world. Take the time to enjoy it and realize how special it is. And with that, let's talk about the mouth to mask. So the bag valve mask. This is where we can actually have ventilation occur, right? Can deliver up 100% O2. When you bag someone, don't forget to do what? Connect the O2. Otherwise, you're only getting 21% oxygen. So you must have a seal for this to work. You have no seal, you have no airway. You have no airway, you have no patient. Mask seal, that good old C and E. And you don't actually compress the mask on the patient's face, collapsing their airway structures. You pull their face up into the mask. We'll practice that in lab.
It is crazy how many people get that shit wrong.
Yeah.
Like when I researched all of Atlanta, there were folks that couldn't get that shit and they couldn't understand the seal. I'm like, bro, like it's not that hard.
It all goes back to training for the basics, mastering the basics, not just checking someone off so we can say we did check them off. Now that comes to a problem why the state of Georgia has minimums when it's talking about instructor ratios. Like there's supposed to be 1 instructor to 6 students. Otherwise that span of control is spread too thin. And otherwise they're not going to get the full shebang of education that they need. Example, ABC over there. 50-1. Allegedly. Allegedly.
Does that change like the AHA? This AHA, after you become an experienced instructor, you can go 9 students per instructor.
The old man up there in the Roswell location, he can hold 10 by himself. And then the states approved that. I've seen the email from like the region director. So yes. But then again, he's got 48 years experience versus 1 or 2 years, if.
Yeah.
So the bag valve mask, it's disposable. It is not for reuse. If you've played any kind of training department, you've probably seen like, well, we got a bag BVM around here somewhere, and it works about as good as a screen door on a submarine. And then the mask that you seal on their face is like partially deflated because it's so old. They're only meant for one use. That mask should have a inflated plastic on it. It should be inflated because it can form a good seal. So there's no pop-off valve or capability to disable. It has an oxygen reservoir, one-way, no jam inlet valve, transparent face mask. And if you're lucky and your department loves you and wants to save patient lives, it has one of these. What is this? PEEP. What is PEEP? Positive in expiratory pressure. PEEP keeps alveoli open. It increases surface area for more gas exchange to take place. This is an oxygenation device. It keeps the alveoli from returning to level 0. I'm going to show you a video today of PEEP and how it works.
So that's what we're talking. That right there is when talking about adult mass spread, because infant mass and
They're different.
neonates do have that pop-up.
They have that pressure pop off because it protects you from barrel trauma with them, because that is so easy. When I teach people to do BVMs for infants, I teach them the crab claw, 2 fingers, the thumb. That's how you squeeze a baby bag. You don't use the whole gorilla hook here.
Yeah.
Don't use that whole thing. Crab claw. Crab claw. For you, it's probably not a problem.
I also teach that
You have little hands.
only reason you should overload or override that pop-off valve as a switch is in situations where possible drowning or cystic fibrosis.
Drowning, cystic fibrosis, I would just say even ARDS, anything that's going to be adult respiratory distress syndrome. So that kind of patient will need a PEEP that's way, way, way up, because their lungs are basically hardening. It's going to take more pressure to open the alveoli and keep them open. ARDS can usually set in after a really bad trauma and your body's gone through all that inflammatory processes, or like a long medical disease that's had your body inflamed for a long time. Eventually you're going to run out of juice, and the body cannot keep fluid from flowing into your lungs anymore. The pressures that kept it out, those mediators are gone. Does that make sense? So you're gonna need a lot more PEEP pressure, a lot more positive pressure. An example? Let's say, oh, I remember one. I had a critical care transfer I did, and we flew this girl to, I think, Cleveland Clinic from Atlanta. She went from Shepherd to Cleveland for whatever reason, but she had a 4-wheeler wreck and had a bad brain injury. And she'd been on a vent so long and been so sick so long that she had developed ARDS. So her lungs had started to kind of harden, and there was fluid always in her lungs, and they couldn't keep it out. So the normal physiological PEEP for me and you, because you have some right now, you're creating back pressure in your lungs to keep the lungs open. Yours is like 3 to 5. They had her on a PEEP setting of 20, which is way, way, way more. But that's the only way they could force air into her lungs to keep them open. But again, it's because she had been on a vent so long and she had been sick so long, her body had kind of ran through its kind of healing mediating processes, the chemicals that would heal her. Make sense?
Mhm.
So that was a pretty bad one. And then we,
Can't remember the name of antibiotic. It was an antibiotic that you give, that you can get in hospital via IV. It's extremely corrosive over a long period of time, and the same process if you have to have the antibiotic for
is it vancomycin?
maybe. I just know that my Jackie was telling me about it. She's been having to give to one of her patients that they have to give and then flush immediately behind just because it's so corrosive.
Interesting.
She said that that person started having lung problems. It sounded similar to that.
It could be similar to that. Sometimes the cure is worse than the disease, depending on. It's like a friend of mine was like, he was put on depression meds, you know. He's going through a lot. So he got him put in depression meds. He's like reading the side effects. He's like, weight gain, erectile dysfunction. He's like, dang, this is worse than, I'm even more depressed now. I'm gonna get fat and I can't do things I like to do. Anyway, so remember, what was the average adult tidal volume we was talking about earlier? Around 500. The real equation is really sorts out to between 4 and 8 cc's per kg. But again, we're working that off of ideal body weight. You know, so let's take a 500-pound patient. Are they really going to breathe 2,000 mLs per? No. The body may be this big, but the lungs are still that big. So we got to kind of take that into account when we're building our little treatment care plans for these patients. It's pretty safe just to say, let's go off of chest rise, because 500 mLs is about the average. Sometimes bigger people will be 700 or so, but there's also that BVM has the ability to give 1,000 to 1,600 mLs. Is that a lot more? What could be caused by a big squeezy bag? Barrel trauma. You could pop lungs, damage things down there. So deliver each breath over a period of 1 second. What does that mean? 1001 or 1 Mississippi. Squeeze it fully, slowly. Watch the chest rise. That is it. If you are the bagger and you have a CPR patient or whatever, what is the ratio for BVM to compressions? So let's say you have a patient cardiac arrest with no airway in there. You're just bagging them and somebody's doing CPR. What's your ratio?
80 to 120 beats.
I'll go. All right, so compressions would be 100 to 120, but 30 to 2. We're looking at 30 compressions. Yeah. So with no airway, it's going to be 30 to 2. Every 30 compressions, you do your 2 breaths. And when you have an airway in there, now you can do continuous breaths. That's where the change happens. So if a paramedics came and put a ET tube down, now we can do continuous breaths. So we do still need to have kind of limits on ourselves. We talked about earlier how just over bagging can do what? What do you think there, Raph? Gastric distension. But what else is happening inside the chest? With just too much bagging, you got compressions going.
You can't pop the lungs. Can you?
Actually can pop the lungs, but what else? That pressure inside the chest is going to compress the vena cava. If you're over bagging your patient, say that again. So decrease the blood flow back to the right side of the heart. So you're working against your compressor. So American Heart has numerics for us to follow. So who knows what they are? If you've got an ET tube in, you don't have to do 30 to 2 anymore. You can count to 6 and give a breath. So 1 breath every 6 seconds equals what? How many breaths a minute? Like 10 to 12. 10 to 12. And that's good right there. I see. I saw your pharmacology test.
You got.
That's true.
Breath every time you take a breath. That's how I know it's a few times. So every time you take a breath, give them breath.
That's fair. That's fair. So the BVM, it's only as effective as the seal you got. Air leakage results in decreased tidal volume and hypoventilation. Decreased tidal volume. You have to have a good seal. How do you ensure a good seal? Chest rise, feeling around it, making sure that they've got a good seal, predicting a difficult ventilation. How can you predict difficult ventilation? How about beards, obesities, obstruction, and trauma? We call it boots. Beards, obesity, obstructions, and trauma. You can predict a difficult ventilation because if they got a big beard, that is glorious and beautiful, then they'll be harder to bag because it can't seal. But what if they are kind of chunky? Well, that'll make them harder to bag because why? There's fat in the way. There's neck meat in the way. You have to really try and manipulate that airway to open it and get that air down there. So air leakage is bad, okay? Remember to pull the face into the mask and not push it, as this can impede what would otherwise be a patent airway. That is extremely important, especially in regard to pediatrics. Their little airways are way more soft and way more malleable. What does that term malleable mean, Martin? Small. How about moldable, compressible, squishable? So malleable, they can be compressed much easier. So an adult patient can still have the same problem. You could actually obstruct the airway by compressing, pushing down on the face. And I've seen this happen. I've had to correct people on scene because I admit that, you know, when you're doing a cardiac arrest or you're bagging somebody, they're usually on the floor laying supine, right? And you have to get on the floor and be on your knees. And for us that are more seasoned, that is not as fun, especially over a period of time. So what do you see them doing? They're leaning forward, holding a mask seal, but they're also kind of putting their body weight on the patient's face. That's compressing the airway. Is that helping or hindering patient care? It is hindering. And that's bad, okay? So allowing the patient to exhale between breaths. So if the patient is still kind of spontaneously breathing, what we could be doing is breath stacking. And what we could be doing is also trapping CO2 down there. So allow the patient time to exhale. Now, if you've got them intubated, you need to make sure that you are doing what? Have them on CO2 monitoring. Because if the CO2 is rising, that means it's going to be what? You're going to have incomplete alveolar emptying. You can see it on the waveform. It's not returning to baseline. So how do I get rid of all that extra CO2? I just stop what I'm doing, push on the chest and let the air come out. What if you've got them intubated? Pop the BVM off, push on the chest, get that stuff out and go back to town. Makes sense? It sounds like it. You're thinking overcomplicates it, right? Don't overthink it. I need to get this air out. Pop the thing off, push on their chest. Get out of there. Yeah. There's lungs in here. Think of them like balloons. How would you get air out of a balloon? You squish it. Let the air out. That's it. So it also might be necessary for what? Like I just said, to gently compress the chest wall to aid in that. This is true with patients that are intubated with smaller diameter tubes, whose airways are difficult to maintain. So if you do needle crike someone, are they going to be able to exhale as well? No, probably not at all. So honestly, what you probably have to do is give a bag, pull the thing off, and push on their chest. Bag them, take the thing off, push on their chest, because they normally have all of this, mouth and nose, giant diameters, to allow air to flow out. Now what do they got? A needle head. You understand the problem? The diameter has changed, it has shifted. So also do not disregard the placement of an OPA or an NPA to maintain an airway while you're hyperoxygenating. It's important to hyperoxygenate your patient before intubation. Why?
Gives you a longer time to be able to see without negative effects.
Very good. You build an oxygen reservoir up, you have a longer time that they can go without a breath because they have O2 in their system. The patient will not suffer brain damage and die because you don't intubate. It's because you don't ventilate. You ventilate, they can live. Worst case scenario, you can't get the tube. As long as you bag them, they have a chance of living. That moves air in and out. And that will oxygenate the cells, the muscles, the tissues, all that. So OPA, we size it from the corner of the mouth to the tip of the ear. Make sure you got the right size. Put it in correctly. It's going to keep the tongue from flopping back over. When would you not use an OPA, Chamberlain?
Like severe facial trauma.
Okay.
If they won't tolerate it, with a gag reflex.
Okay. If they won't tolerate it, what if they got a gag? How can I test if they got a gag, Martin? Oh, play with their eyelashes. The eyelash reflex. That's a good one. Back in the day, we just did what? Blah. Well, he does have a gag. So, prior to advanced airway procedures, or the airway can only be maintained by BLS techniques. BLS should always precede ALS. Perfect positioning, perfect bagging will precede any intubation or any kind of cool medic stuff you could do. Make sure the bagging's perfect. Make sure you got a good seal. Make sure you're hyperoxygenating your patient. Make sure that you are testing the airway and validating that it's going to be difficult or easy, or looking at it. Make a plan. Have a plan A, B, and C, and then lay out all your equipment. Lay it all out. Lay it out as if you're going to get it the first time. Lay it out as if you're going to have to try a second time. Lay it out as if you need a third option, a rescue airway, an IGEL, or even a surgical airway. Have everything laid out. That way you're not looking for it. That all starts when? High. Even before. Even before.
In the morning during your check.
In the morning during your checkoff. I know where my laryngoscope blades are at because I put them there. This other medic in the shift before me might have put them somewhere else. Guess where I'm going to put them? Where I know where they're at, where I can conveniently reach them. I will then personally test each blade to make sure the bulb is working. I'll make sure the batteries are good and in working order. My bulb is bright. My light is working well. I will do that for all of my equipment because at the end of the day, I am responsible. I take ownership of my time on that box. So it all starts before even then. Oh, we've already talked about the BVM a lot, so I think we can get into it. Oh, PP. Y'all too young for this. Let me see what I can do here. Let's check it out. Let's see if we got this thing moving and grooving now.
Bagging without PEEP. Yes. See how the lung collapse?
This is you bagging without PEEP.
Hardly any alveoli.
So with bagging without PEEP, the alveoli are going to do what? Return to level 0 and collapse upon themselves again. Your patient does not have blood flow that they would normally have. That does not have the tone, the muscular tone they would normally have from a patient that is now in cardiac arrest. Let's keep looking.
They're just going in and going out. Okay. How fast he's squeezing that bag. All right, now we're gonna add PEEP to this.
Let's add PEEP to it. We see how they return to nothing. Now he's got PEEP on there. Bag it. Let it return. Whoa. Look at all those alveoli being recruited.
Why the lungs are staying.
The lungs will stay inflated. Air will be in there.
And you can't over ventilate this patient? You can, you certainly can. So you
All right, let's pause. What you got?
With the lungs staying inflated,
He's got it on the max setting.
okay, I was.
Yeah.
just about to ask, do you need to decrease
Yes.
how often?
So very much so. So when the patient goes into cardiac arrest, they lose all PEEP, all positive and expiratory pressure they would normally have if they were awake, alert, and breathing. So the PEEP valve, it's just a twisty knob here. You put this on any of your BVM, all the way open is 20, and it's got numbers on it. I can go all the way to 20, or I can start it at 5, which is your physiological norm. He's showing you 20 right now, and that seems extreme because you could hurt somebody with this. So he's going to bring it back down in a second, back to like 5, and you can see that effect here. But yes, good question.
adjust your PEEP anywhere from 5 to 20. 20 is the max I would do, and you just watch the patient. You're driving for an O2 sat of around 94. You need to be at 100%. You adjust your PEEP.
So what we're talking about here is driving this ventilation by using a couple techniques. Drive your ventilation by watching your patient to make sure that they're not having some increased airway pressure problems. You can tell because they'll start to squirm if they're alive and alert. You can also add PEEP to your patients that are not in cardiac arrest and that are actually just needing extra to be bagged. Not every patient in cardiac arrest, respiratory arrest occurs too. Sometimes you can have a pulse and not be breathing. So for these types of patients, you need to be considered with watching them. Also watch their O2 sat, 94% and above, happy. What else can we watch? CO2 levels. Try and manage them between 35 and 45. That's how you can keep this patient ventilated perfectly. Perfectly ventilate them with PEEP, O2 sats, and CO2, and use waveform capnography to see what their exhalation looks like and what those graphical outputs are. Everybody with me?
The only way you can increase FiO2,
Look at
you're
that.
already on 100% the way to increase the number is through PEEP. Like that means breathing pressure. That's going to cause pressure, decreasing cardiac output, decreasing SpO2, causing you back faster, just get into this vicious cycle.
What's your current PEEP setting?
So our current PEEP setting on this one right now is 20.
He's at 20 right now.
Back it back down. This is 10.
We got him at 10 now.
This is 10 at PEEP. So you can see it's returning out of VLI. This is 5 of PEEP.
Now we're at 5. 5 of PEEP.
So you can see that's our physiologic norm. It's almost like not having.
Look at that. That's 5 of PEEP right there. So PEEP, use it. PEEP helps you get people back from the dead. PEEP helps your respiratory distress patient recruit alveoli. You can bag as perfectly as you want to, but the BVM is not going to recruit all those alveoli. What's going to help recruit all the alveoli is this little plastic device right here, returning the patient to their physiological norm of the back pressure that's going to keep those lungs open, will save their life. Why do I get patients back when I do my arrests? There's a ton of other reasons, of course. Not using feedback devices, not using capnography, not having PEEP. You're behind the 8 ball if you don't have this. Do you see why? Because every time you give a breath, you return back to level 0. The alveoli collapse upon themselves. You feel me? All right, I like it.
What setting is it supposed to be at when you?
So we start at the physiological normal 5. If they need more, we can adjust it and put them at a 10. I don't go over that for anybody unless they have ARDS, and I know they have ARDS, and I don't know that in the field usually.
Does that include like rest patients?
Arrest patients, you'll probably want to put them at a 5. You'll be recruiting alveoli, but you won't be overblowing the lungs, because a lot extra PEEP can pop lungs because it keeps them inflated. So you have to be careful of that. So watch your patients, start at a 5 and go from there.
Because that's not accounting for it, it's the interthoracic pressure or negative pressure, so the lungs can't collapse like those are, so just that 5 should be good enough to help.
Will that work for feeds too?
Peds need PEEP as well, but you have to have an appropriate sized PEEP for their BVM. So there has to be an appropriate sized PEEP for their BVM. All right, we're back to the transport ventilator.
Is there a pediatric?
There should be. But I mean, let's start with this. Y'all ain't got this yet. Believe it or not, Sandy Springs brought me this one. I use it as a show and tell for you in hopes that you'll be like, hey, I'm motivated enough to now go and write a paper or a proposal to have my service purchase these, because they're relatively cheap and they can make a major difference in resuscitation ratios and percentages. So now we have automated transport ventilators. Why do I want to talk to you about vents? You may ask me, why, Josh, are we talking about ventilators? I am a 911 medic. Man. Well, we're talking about industry standards, and standards of industry now are that some trucks actually have vents on them. Think about a paramedic unit. I have a machine that can bag the patient, that can bag them perfectly, that doesn't get tired, that gives the perfect amount of air every time, that can monitor airway pressures, peak inspiratory pressures, alveolar pressures. It'll alarm if I have high pressure alarms. If my compliance with the ease of which the air flows in is changed, I'll know. If I have low pressure alarms, if I have a tube leak, I will know it, because a vent can tell me. Can recruit Joe Blow tell me that? No, he's just going to sit there and look stupid and just keep bagging. So a vent can be very, very effective. Also, you never know the direction your career may go. You may decide to go do critical care medicine or be a flight medic one day. But there are vents on some 911 trucks here in Atlanta. Even when I was working at Grady on a 911 truck, they would occasionally ask me to take a vent call. Now, the great thing was I could tell them no. But why would I do that? I can get out of the rotation for a while. And I always had a deal. I'm going to stop and eat. And they're like, okay. Fair.
How does y'all dispatch work?
Right now, it's silent dispatching pretty much. Like they got this new rescue Zoll software, and you pretty much just hit a button when you're there, hit a button when you're leaving. You put the hospital, and then you also like hit a button and it GPSs you everywhere. I actually like it a lot. There's way less radio traffic. Really way less radio traffic, yeah. I'm fond of it. I don't want to talk about dispatching. So vents come in all shapes and sizes. They all have their uses and their pros, their cons. Also, there's vent questions on the National Registry. I seen them. So the automatic transport ventilator, this thing is automatic. It usually comes with like 3 buttons. Doesn't have digital readouts, doesn't have the ability to really monitor pressures, and it's also powered by oxygen sources. And it's powered by what? Plugging it in. I was supervising one day, and a 20-year veteran medic called on the radio saying she needed assistance 911 backup, like right now. Her vent patient was crashing. She couldn't figure out what was going on. So I drove lights and sirens for 12 whole minutes to get to her, only to have to plug the damn vent in for her. It ain't got no gas in it. So she was bagging him when I got there. So you should always have a BVM available in case any vent malfunctions. Anytime you decide to take a vent patient or deal with patients on a vent, and you can deal with patients on home vents. There are patients that call 911 who have home vents. You should know at least a little bit about ventilators. They have settings. They have either pressure support or ventilatory support. They have different modes like assist control, where they're just going to completely breathe for you, or SIMV, synchronized intermittent mechanical ventilation, where it's just going to assist you. It's going to synchronize with the breath that you have and then assist you up to a certain tidal volume or respiratory rate that it desires for you to have. They have different pressure settings. Is it supporting you with pressure or volume? It's important for you to know at least a little bit about these vents so you can at least mitigate a patient that calls you for a 911 problem, correct? So these automatic transport ventilators, they run off of like 3 buttons. They don't have pressure settings that you can set. They don't have none of that. Now, some of these other vents, they're fancy doodads. They can tell you the pressure in the alveoli right now. They can alarm with certain pressure alarms. They can do all the fancy stuff and really make this very complicated. The automated transport ventilator has 3 buttons: tidal volume, respiratory rate, adult or child. That's it. That's a win. What you got?
That is pediatrics and adult.
So this can do both.
Yeah.
Hell
Don't
yeah.
Have a separate for pediatric or adult. If you set the 5 and then go from there.
I like it. So we answered the question. This right here can work for a pediatric BVM as well. So there's only one. You can just attach it and set it at 5 and go from there. I likes. Here I was thinking there was an extra, like a little small one you had to buy.
That's what I thought too, so I looked it up.
I like it. So CPAP. Tell me about CPAP. What minimum pressure should I have, Raph, before I give it? You don't know? I said it earlier. We just 15, a pressure of 15.
Oh, you said a pressure, like a blood pressure.
Blood pressure, yes.
Have at least or higher, 95.
Okay, so depending on the protocols you have, I've seen mostly 100 and over, but I have seen one service that had a 90 and over. But what if you got an 80 over 40 and the patient really needs that CPAP? What you gonna do about it? Give them fluids or pressure. Now, what's the problem with giving fluids to a CHF patient? They already got a lot of fluid in their lungs, and a problem with getting fluid out of their left ventricle. It could back up into the lungs and you could drown them. So be careful with any fluid you give them. I'm not sure that would work really well, because the problem is going to be more mechanical. The hypertonic fluid is going to go into the right atrium because it's going to increase preload. It's going to make its way through the heart. It's going to get back to the left ventricle. And the problem is their left ventricle is crappy. So a lot of that fluid is not getting out. So it's going to back up into the lungs. So now we got hypertonic solution in the lungs. It's going to pull more fluid into the lungs. See the problem? I don't want that. So most of the time, it's actually better to
Dry them out.
Yeah, dry them out, push air through it with a CPAP, or put them on a pressor. The pressor is going to raise the blood pressure without putting a whole lot of fluid in them. Like we said earlier, like a Levophed, like a dopamine, like an Epidrip, something to have an alpha adrenergic agonistic effect. What does that mean there, Martin? Alpha adrenergic agonistic effect.
It's what not mimic, but it's support alcohol.
Okay, so supporting the alpha 1 receptors, it's going to attach to them, agonize them, increase cellular activity, and cause vasoconstriction, which will increase blood pressure like we want. Blood pressure is now high enough for me to do what, Raph? Put them on a CPAP. So CPAP, non-invasive mostly, increases pressure in the lungs, opens collapsed alveoli, pushes oxygen across the membrane, and forces interstitial fluid back in circulation. So, in a nutshell, wet lungs, CPAP. Can't breathe real good. You need to force gas exchange. If they can tolerate it, CPAP. So, that's good. Guidelines. Patient has to be alert and able to follow commands. CPAP is not a BVM. CPAP is not ventilation. CPAP is oxygenation, because ventilation is moving air in and out. CPAP is what? Just air in. BiPAP's moving air in and out at 2 different pressures. So patient has to be able to follow commands. There has to be obvious signs for respiratory distress or submersion, rapid breathing. They should be breathing pretty fast, and a SAT less than 90. CPAP is invasive. They need to meet criteria. Usually it's at the very kind of end of your respiratory distress protocol. Now, there are times when I show up and we have already went past any nasal cannula fixes. We've already went past any kind of like step process here. We're already at CPAP, and we're trying to avoid a what? What size tube do you wear, sir? We're trying to avoid that. So if I get there and they're already CPAP ready by their presentation, I just go ahead and pull it out and put them on. I got there this one guy, he's a tripod, and I can hear wheezing across the parking lot. He can barely get words out. And, you know, we're starting to do the neb and all this stuff. And I was like, man, you ever been intubated? He's like, yes. 2. I was like, 2 days? No, weeks. He was intubated 2 weeks prior for the same problem. He had locked down to the point he had to be intubated. So I was like, cool, here's a CPAP. Let's just avoid that again. And while he was with me, we avoided the tube. We got it set up from like 70 to like 91. But when they got to we took him to Emory Midtown because that's where he wanted to go. What'd they do? They took him off CPAP. What'd he do? Deteriorated rapidly. What'd they have to do? RSI him and tube him. Okay. The CPAP, once you just pull it off somebody, what's going to happen? The alveoli going to do what? Collapse, go right back to. So I always hated Emory Midtown. I brought patients in there on CPAPs and like extreme respiratory distress. I'm like, hey, I need a room. He can't breathe. I'm about to run out of O2 because we only have the small O2 tanks. Grady doesn't carry big ones. I've got 200 PSI left. I need a room now. Like, I don't normally get spicy, but like, you sit there on your computer or you'll be here over playing on your phone. It's business time. Get up. That's uncomfortable to do, you know, but you have to advocate for your patients. Even if it means standing up to their family, to themselves, or even to the nursing staff there. I get it. You're tired and burnt out. If you don't like it, then go to Peds or go somewhere else. Go to Walmart. I don't care. If you're here to do a job, give me a room and start taking care of this patient. I am about to be out of resources to help them. Because at that point, I'd already given them probably 15 milligrams of albuterol, the Solumed, the Decadron, the mag sulfate. Now they're on CPAP. I'm trying to keep them from buying a tube. And now that I'm on hospital grounds, what's EMTALA? They have to treat the patient. That is their patient now. They're responsible legally for that patient now. I likes. Other CPAP information. Unable to follow commands, respiratory arrest, or agonal respirations. Unable to speak. They're hypoventilating. Why will CPAP not help hypoventilation? They're not breathing, so it's not ventilation, it's just oxygenation. What about hypotension, Rhea?
It's on the bottom of the blood pressure.
Bottom of the blood pressure. What by what mechanisms? How?
It's pressing down on the.
So it's decreasing the preload. Very good. Pneumothorax or chest trauma, would that make it better or worse? Finish him. Closed head injury, facial trauma, cardiogenic shock. Unable to sit up, unable to fit the CPAP systems. They're not really one size fit all. You got somebody with a big old water head, it ain't gonna happen. So comprised of a generator, mask, circuit that contains corrugated tubing, bacteria filter, and a one-way valve. Why the bacteria filter?
You don't want to end up putting the patient in, or giving the patient pneumonia.
I do not. a lot of vents, a lot of vent patients, a lot of CPAP patients, a lot of intubations have filters. So when you blow air in, it's filtered air. Everybody feeling good? I like it. You got a question? All right, let's hear it.
You may have.
All right, so advanced airway management. We've talked about bagging and tagging. We've talked about CPAP. We've talked about all these other little devices. Now, let's talk about paramedic stuff. One of the most common mistakes with the cardiac arrest is that you're jumping on that advanced airway too soon, too early. You don't adequately maintain a patent airway and use basic techniques first. You have to maintain a perfect seal. You have to ventilate perfectly before you can get this advanced stuff. Here's a sad fact. There are some EMS services out there that have a low, very low intubation success rate. Why do you think that is? They don't do it very often? All right, so let's take a fictional fire department. Oh, shut up. I'll read my mind. Let's take a fictional fire department that has a division that is responsible for maintaining the safety and well-being of an airport. Okay. Let's pretend I went to this location 3 years ago and taught an airway class. Asked every medic there over 3 shifts when the last time they intubated was. Their answer was years, every one of them. They all jumped on an eye gel. Why do you think that is? Easy button, lack of training, fear of failure because they don't do it very often. It sounds like they have plenty of opportunities to try. Why do they not go for the intubation? What do you think, Chamberlain? This is a fictional department, does not exist. Not affiliated.
It's easy. We haven't done it in a while, so they're not confident in their skills. Don't even know where the equipment is. Maybe.
Don't know where the equipment is. So let's talk about another fire department. This fire department is a large metropolitan fire department that shall bear no name, that has stations all over the place. They have towns in this place called, you know, they rhyme like Suckhead and Rankhead, you know, things like that. You know, it's a fictional place. This fire department actually has video laryngoscopes, which increase your chances of actually intubating successfully, and they don't use them. Why don't they use them? What do you think there, Martin? If
Grady's away.
Grady ain't always on the way, especially now with staffing being where it's at. I will give you some good news. The guy that's running the show now, he is, for lack of a better word, the man. He was an amazing supervisor. He was a good man. He was also understanding. A lot of people are going to come back to Grady now. Like, I hadn't picked up a shift in years, and now that he's back, I actually picked up one a couple weeks ago. I mean, he's the legit real deal. But even with him there's still going to be staffing problems. There's not going to be enough people because the volume's too high, and they're going to take a while to replenish those people that left because of former leadership, or they just want a greener pasture. A lot of people don't want to be that busy at work. I was weird that way. I like to be busy. It makes the shift go by fast. I like the stimulation. I couldn't stand when I was at the slow fire department or the slow EMS service down in South Georgia, and I run one call a night. I don't know what to do with my hands. So they don't use their video laryngoscopes. So jumping on to advanced techniques too early is a problem, but also there's a lot of services that are failing at airways because they're not training. When I was in South Georgia, I'd probably intubate 3 times a year because I didn't have but that 3 arrests per year. Just didn't have a lot of call volume, maybe 12,000 calls a year across 3 ABC shifts. That's not a lot. That's maybe 4 calls a day. You couldn't tell me that back then. I'm so tired, I'm busy. We was up all night. We ran all night, man. You know what I'm saying? Then I look back, I'm like, I used to work 48s and then go work out immediately after. I wasn't that tired. Couldn't do that after a Grady shift. Could you do it? Hell no. I'm gonna go home and sleep and let the nightmare end. So primary reasons we're failing is we have a lack of training. We have a lack of perfection of BLS skills. We said earlier, how crazy is it? There's people in this department that come to research and they can't even hold a bag right. They can't even hold a bag right. So they have a failure for lots of reasons. They fail to maintain a patent airway. They fail to pre-oxygenate, and they fail to ventilate. A thing I've said several times a day is what? Patients don't die or suffer brain damage because you don't intubate. They suffer brain damage and die because you not intubate. So the success rating across a lot of these services around here is like, they got like a 40% intubation success. Video laryngoscopes could bring that up to 80 or 90%. Using a bougie could bring that up to 96%. IAMED did a study on that. They found that the use of a bougie with intubation increased first pass intubation success rate to 96%. While you got these guys at this fictional airport with a 0% because they're not even trying. This other little small service up in North Georgia, you know, that will remain nameless, but it rhymes with, you know, stumming or rumming, Georgia. They have like a 30% first pass rate. Now, is it always our fault? No, it's not always our fault, because even I have missed intubations. Even when I worked at Grady, I would do 2 or 3 a night. There's sometimes I'd miss. Did Tracy ever miss? Yes. And she's one of the best to do it. If you've tried an IV, you've missed an IV. If you've tried intubation, you've had intubations you just couldn't get. There are some correlation with this patient is just not intubatable in the pre-hospital setting. So the ideal conditions for intubating a patient: ideal lighting. It's well lit. Oh, lovely. Positioning. You can position them perfectly. You have all the help you need. You have time to prepare, plan, discuss. You have the option to abort. They have an empty stomach. All right, sir, we're going to intubate you in about 4 or 5 hours. Let's not have anything by mouth after midnight, okay? And they have backup available. You know what I just described to you? An OR intubation. According to the Academy of Anesthesiology, pre-hospital intubation is, by their definition, always deemed a difficult airway. So ideal conditions, you got all the light. You're not on some grimy bathroom floor where they haven't paid the power. Other conditions, you have all the help you need. It's not just you and your damn brand new EMTB partner who ain't never even seen a laryngoscope blade because they went through an accelerated fire academy EMTB class where blah, blah, blah. Yeah. Do you have time to prepare, plan, and discuss with other experienced providers? Can you just pull out and just decide to do something else? No, you have to get this intubation. You have to get this airway somehow. Do the patients always have an empty stomach? No, they just had KFC and beer. And is there always backup there to help you? Let's say that Martin gets his medic and he's out there on the engine. You got a whole crew of guys there, but are they going to be able to back you up at this level of the game? ALS stuff. No, you're probably the only medic there, right? Unless you're at Station 9 with Tyler Dean and freaking Gavin Lamb. Stuck there together. You chose this. Now, what about the ideal patient? Intact and clear airway. They have a wide open, big mouth bass mouth. They've already been pre-oxygenated. They have an intact respiratory drive. Normal dentation, which means that all their teeth are there. Teeth help hold the shape for the seal of the BVM mask. Clearly identifiable intact neck and face, big open nostrils, good neck mobility, and they weigh more than 90 kilograms. They weigh less than 110. Anything less than that, guess what? You're not ideal. You're kind of small. Your airway structures are smaller. Anything bigger than that is what? You're going to run into some big neck syndrome. You want to see the perfect intubation with all the landmarks. Let's take a look. Woo! Pretty. What do I got here? I got this big wide open glottic opening. I got these vocal cords showing me the right spot to hit. I got the epiglottis flopped out of the way. I got the anterior commissure. I got the cricoid ring. I can see the cricoid ring there. I can see the false vocal cords. I can see the true vocal cords. I can see the posterior cartilages. It is beautiful. This will be easy. Here you go. Slide right in. So the patients that we get are not normally like this. They don't have intact airways. They don't have big wide open mouths. They're usually not in that great a condition. Why? They're immobilized, traumatized, compromised, prioritized, and beer and pizza-ized. How do their airways normally look? Let's take a look. Ooh, you swole, baby. Intubate that. They have a swollen and damaged and inflamed epiglottis. Is that going to be easy to get out of the way? Or it looks like this, a torn up, floppy epiglottis. Probably your poor intubation skills. This thing right here is a blade. Let me show you something real quick. I'll come back to the camera in a minute and show you too. So looking at this blade here, this part right here is sharp and that can tear and damage tissue, but this part is flat. That's where we want to try and intubate there. So most, if not all of our patients are already difficult airways by OR standards. Why should you work to try and identify a difficult airway? Why should we have mnemonics and other things to help us? Well, according to the American Society of Anesthesiology, there's a strong agreement among consultants that preparatory efforts enhance success and minimize risk. Let's translate. Prepare, plan, and you will have a what? A better success rate. So, it also provides strong evidence that these specific strategies facilitate the management of difficult airways. It is thus identifying that potential difficult airways, it is essential to prepare and develop a strategy. You know where I got these slides? This airway lecture is from all over the place. This is from the American Society of Anesthesiology. This is from the National Airway Management course. I didn't make this up. I pirated these slides from them. What does that mean to you? Well, many anesthesiologists